Welcome back, listeners, to Drug Diversion Insights. My guest today is Dr. Suzanne Waddill-Goad. She is a licensed nurse and has extensive experience in leadership, including roles such as Chief Nursing Officer. And it is from this perspective that she will share her experience with diversion events. But before we jump into that, Suzi, welcome. And tell us a bit about your career and how your work focuses, what work you're doing now. What are you focusing on now?
Great. Thank you, Terri, for having me as a guest. Let's see. So my clinical career began very young. So I had some experience as a respiratory therapy technician. Then I moved through a number of different roles. When I was actually in college, I did some transcription. I worked in medical records while I was going to nursing school. And then my clinical areas that I focused on in nursing were, I just did 1 year med surg, and then I moved more into critical care. That was really interesting. And the emergency department. And so I had a pretty broad breadth and depth of experiences with those, and then moved into a leadership role probably about the mid 90s. So it's been, some time, obviously, from then to now. And I, kind of worked my way, not traditionally into the chief nurse's office, because I was more on the operations side. So doing like operations improvement. And then became the chief nurse. So I didn't take the traditional path that many do, where you're a manager and then a director, with specific service line. So it was great because I got to look really across the whole organization, which gave me a lot of interesting information that was useful, in that role. And then about 22 years ago, I started my own company. And so I really wanted to focus on operational improvement. And then in addition to that, do some interim leadership assignments. And so I've had many experiences, doing those. Many of them have been in the nursing director roles. I've done the chief nursing officer. I've done quality and risk management, either together or separate. And so I've traveled, in many states across the country and seen lots of interesting things along the way, and met some very nice people in my travels as well. And so that's kind of in a nutshell.
Yeah, that's pretty cool. That it's neat that you kind of came up from the beginning of, you learned a lot of stuff in healthcare before you ever got to that CNO role, which I think is great, because I think sometimes if they're too narrowly focused, they don't, it all interconnects. And so you really understood a lot of those things. And the interim, I'm curious I've done a little bit of interim myself, which I think is great. I mean, it's a different you're in there to do the job, but there isn't that whole political tied up with, I found it to be a little bit liberating, actually.
Right. It's very refreshing.
You can make changes. You're there to, that's neat. So you've been in healthcare as long as I have. So you've seen a lot of things. So I'm curious to hear from your perspective, what has changed when it comes to nursing? I see it from the pharmacy perspective, but I hear it when we're talking about holding people accountable because of diversion risk and all of this stuff. And, you can't go outside your scope. And the more mature nurses get a little frustrated. It's like, why? I know what I'm doing. I know more, right? At the bedside, what to do. So I have seen that change. I think more restrictions, shall we say. What is your perspective on how things have changed with nursing over the years?
Well, I think it's pretty interesting now that we have 5 generations of people in the workforce. And so like you described, we have novice all the way to, expert nurses practicing. In addition to that, we've had so many changes, like if you think about, during the 2000s when we started getting, electronic records of whatever type, for a lot of them started with order entry. So, like with pharmacy, to begin, and then, moved more into an electronic health record. And so I think that, that's been a big change. I think the other thing is now looking at different new models of care. And so trying to figure out, are there new ways to do the same work and better ways to do the same work? And can we leverage the knowledge of the nurses who are expert nurses, who many of which may be thinking about leaving the workforce, but leverage their knowledge in a way that can help onboard, some of the more novice or younger in the profession nurses. And so I think that's kind of an exciting thing that's changing. Mm-hmm. The other thing that I see that's changed, a fair amount is the amount of stress and just, trying to do more with less. Trying to do things in a probably not as efficient way as maybe we should. And so sometimes, we've been victims of adding another form, and it can be an electronic form, it can be a paper form, but it's always like adding more. And rarely do we actually stop and look at the entire process without adding more things to do. And so sometimes we end up doing things that I term sort of nonsensical, and they're non-value added just because we always have. And so, a big process person, like, okay, let's look at how the work gets done. Let's make sure the right people are doing the right work. You mentioned scope. So make sure everybody's working within their scope of practice, and specifically for nurses to the, top of their license. So are there things that appropriately can be delegated, to other skills? And the answer is yes. But, delegation itself is a skill, and not everyone, has been, probably trained necessarily in delegation. And, a big part of delegation is supervision. And so just because you ask someone to do something, doesn't mean that they're not necessarily going to do it. And that, part of delegation is following up. And so you have to make sure you close the loop, so I think some of those things with, all these generations in the workforce, people, having different things they want from work, different experiences. We have many different cultures, and so you add on all of those things. And I think people are feeling a different kind of stress. And so I think, with that comes ways to mitigate the stress. And in some cases, like I found in my own research on leadership fatigue, some of the choices people make are not as healthy as they should be.
Yeah. But you're speaking my language. Yeah. We don't want busy work, and we've got to look at things, from that big perspective to see what should we be changing and doing. That all perfectly makes sense. I'm curious. I'm sure you've heard, nurses eat their young, or it's they're really not very supportive for new nurses coming in. Have you seen that? And okay, has it always been that way, or do you think that has come with?
Oh, no. I would say it's been that way since the day I set foot in the hospital, which has been many decades ago.
Okay, so we can't blame that on the increased stress.
It really is not. It's not a new thing, and it sort of is you have to prove your smarts, I guess, is sort of what people are after. Yeah. Which really is not a good way to onboard people, especially people that are new, to the practice. It really is much better to have a wing person, and be on the buddy system. I mean, which is great, and to really have good preceptors that, one, are interested in precepting, and two, are good at it. And not everyone should do it. So that's the other thing, is making sure that, we pick the right people to onboard, new people, and, kind of train them in this particular organization's way, and these are our policies, and these are our procedures, and this is how we want you to practice, and have some standards that are very specific. And, I think when you do that, you develop a culture where the nurses will hold each other accountable. I've had many leadership roles, either interim or permanent, where rarely did some things get to my desk or my office, they were dealt with by peers, which is good, because it's like, well, we don't do things that way. And so, we do things this way. And this is the standard that we all want to, ascribe to. And so I think, some of those things are good.
Right. Yeah. Well, and it's a patient safety issue too. If your new people don't feel comfortable going to the more seasoned people, then they, might be doing things they shouldn't be doing, but they're afraid to ask.
Exactly. Yeah. And you don't want to have a chilled culture, so that people don't have, the confidence that you can speak up and speak out. And that's very important, as for patient safety, that everyone, regardless of your role, needs to speak up if there's something isn't right, or they feel it's not right.
Yeah. So let's talk about diversion or impairment on the job. In all of your years, have you run into any situations where this has been a factor and you've had to deal with that?
Oh, yes. I've seen that in many, many of my roles. Unfortunately, I hate to say that, whether they've been permanent roles or interim. I've had experiences with both. I'll tell you about some of them. Some have been like the best nurses that no one would ever suspect. Yeah. I mean, which is fairly typical, where they don't get questioned. They've also been with people who float. who, are really usually very well received because they're going around helping everyone. Well, that's great. But, with that, you need to have some other, controls in place. One of the other, probably the most memorable one was when I very first started my own business and I was doing my first interim role. Very large hospital, complicated, had a lot of problems, had a turnover in leadership. And I went, and I'll never forget, I got 2 phone calls while I was there that are burned into my brain. One was in the middle of the night, and the person on the other end of the phone said one of the techs in a department had gone missing. And I was like, and they'd already talked to, their supervisor, and the supervisor called me and they said, hey, we can't find this person. And I was like, what are you talking about? What do you mean you can't find someone?
What do you mean?
Where are they? So I said, well, you better like start sort of a search, party and within the hospital and see if you can find out where they were. Well, unfortunately, this particular person had obtained access to drugs even when they were not licensed. And I mean, we're talking about, drugs of abuse. And so managed to get their hands on something that they shouldn't have, which was a narcotic, and decided for whatever reason, which this has not been my experience with, except for in this particular location where people actually did the drugs that they diverted on duty. I mean, my experience has been more typical that people take them and don't do them while they're, on duty taking care of patients, which is better. I mean, it's not good. Either one of those are not good.
Right.
But anyway, so they find this person, unconscious. And subsequently she actually died. So, I mean, it was horrible, and it was a horrible thing. So that was the first one. And then within about probably 2 or 3 months later, I'm in my office during the day. It was on a weekday in the hospital. And 1 o'clock, I get a call from the OR that said, hey, you need to come down here right now. We just had one of our, and this was an anesthesia tech, go on a break, and he didn't come back. And so they were like, what? Well, where is he? So they go looking, and they go into the break room and into the bathroom, and had to find the key because the door was locked. And this particular person had OD'd while on duty. So, had a needle hanging up his arm kind of thing. I mean, now, as you know, both of those situations not only are complicated for the people who work there, for the organization itself, but there's so many regulatory bodies and, people that have to be notified. And so it brings on a whole cascade of regulatory and, survey processes that take years really to recover from. And so it was shocking. I mean, there were many things that happened in this particular organization that I had never heard of, never seen, because I had come from, like the hospitals that I had worked in and that I had run, like a division or a department, were really by the book. I mean, I've always been a very good rule follower, when the rules make sense. And tried to encourage other people to do the same, and if it was a rule that didn't make sense, well, let's figure out, why do we have it? And is there any way we can change it, make it better, for example. But this particular hospital had a culture that was really different. And I mean, I'm sure it got this way, over time. It wasn't an overnight kind of thing, but those were, 2 that were very, radically different than others. And then I'd had, other situations where, depending on what kind of surveillance was used, typically by pharmacy, making sure the reports get to the right leaders, and the leaders actually follow up on the reports, and act on the information, because it doesn't do us any good if we get reports and we don't look at it and we don't use it. And these were really, really kind of reporting mechanisms that looked at, standard deviation. And so was this particular nurse, sort of outside the box of what looked like it was acceptable, with the rest of the patient volume and the rest of the nursing staff. And so, sometimes it was just sort of, on random surveillance, I guess we could call it, that you would identify something. And then some were all the way, like I said, to, being really extreme.
Yeah. Wow. So, a few takeaways. One is, for the hospitals, think it's not happening at their location. It is. I mean, you saw a lot of it in various degrees. And then in terms of your 2 people that went missing, you specifically mentioned the one in the OR. They needed a key to open things up. So that, note to self, right, is like, all of these doors, we need to be able to access them from the outside, I'm not sure where you keep all those keys in an organized manner for everything, but that's kind of an important part, unless you're just gonna, unscrew your door and take it off that way. But and then also the hospital where you had these two incidences, they were clearly different than a lot of the others in terms of their culture and the way they did things, in terms of, because I was going to ask you, how many of these places had what you would call solid diversion monitoring programs in place?
Not many. I mean, and that was one of the things that after, I had experience with that. Well, I had experience in my permanent roles, prior to, being an interim. And so I knew it was something that was always on my radar. So I actually added it to my own assessment list. So when I would typically when I go into an organization, especially as an interim, I'll take, a list of things I want to see. And so I'll look at, data sources, I'll interview certain people, just to kind of get sort of the lay of the land. And so that was one of the things that I always, kept on my list. And so for clients that really didn't have a program, I helped them find someone who could help them implement one.
Right.
Because like you said, a lot of people believe this is not happening here. Right. It's not going to.
Yeah.
And it's like, well, okay, I probably can prove you different, if you give me some data. And so, and I think that's the other thing is that, we have to look after our people, in the event that they make a choice that they're not looking after themselves.
Right. Yeah. And not too long ago, recently, there was a hospital that had a diversion incident and the CNO lost their license, albeit temporarily. I believe she got it back. But, the CNO holds some ownership. Usually I just think about the pharmacy director, a pharmacist in charge that, is going to end up being in trouble. But the CNO did as well. So that's good. That you have.
Well, and as you know, I mean, there are so many people that this had to be reported to, law enforcement, because we had 2 dead people.
Well, and two. I'm like, hopefully you reported the first one so that they weren't like, why didn't you report that one?
Yeah, exactly. So, I mean, so then you have a whole new different kind of thing with law enforcement inside a hospital for a death that's not a typical kind of death, and then there's all these people that have to know, like you said, the board of pharmacy, the DEA, there are things that people don't think of, all your regulatory bodies. So state, federal, joint commission, whatever other kind of quality regulatory bodies. I mean, it was a laundry list of people that just had to be notified. And then, we had to figure out, okay, how do we error proof the systems here?
Right. That's what I was going to ask. I don't know how long ago it was. Do you recall what was done, put into place? Some of it was probably mandatory from the regulatory bodies.
It really was.
They maybe, told you what to do.
Yeah. And so I think there were some, programmatic changes that needed to happen. So things that were, to safety, related to safety and to error proof the systems, and just to have better control of, controlled substances. That you can't, and this has always been, at least in my career, has always been a problem, so typically problematic in OR type areas where sometimes whoever's using the drugs for a patient, you can't leave them unsecured. And I mean, like laying on a table, laying on the counter, in your pocket.
Both your people were techs that didn't have access to,
both were unlicensed. And so they didn't typically have access. And so it was, like holes in the system that were really exploited. And so it was either, fishing things out of, the old type style of needle boxes, or picking up things that they saw that, that you don't really know exactly what it is and what it's for, but it could be for interesting. I mean, and I'm not sure who thinks that way, but, and then really we had to go to the medical staff as well and say, all right, look, if you're obtaining these, drugs for use, you have to close the loop. And so one, you have to keep them in your control. And then secondly, you have to waste it and make sure that you know where it went, from the moment you accessed it to the moment that either the patient got it and it was done, or if you had some left over, to waste it properly, close that loop. And so I think, just helping people understand that, and like you said, there's a lot of things in most people's license that they read once when they get licensed, so they forget that there are all kinds of things that, you're responsible for and that you can be held accountable for. And so I think that was the other thing, is just having a refresh of, okay, most all licensed people in healthcare, have an obligation to, pay attention to what their peers are doing. And if you see something, you better say something. you know, and especially from a patient safety standpoint, because none of us would want to be the patient and have an impaired provider.
Right. Well, I would venture to guess in that OR after that event, they saw things very differently, even without you needing to tell them. Right. I mean, I have found from my experience, procedural areas of all sorts, especially, they're kind of like this close knit family and like, oh, we wouldn't do that. We don't need to worry about that. Nobody here would do that. And so they're a little bit more, I don't know, they can be a little, don't tell us what to do. We got this under control. You know, I mean,
it can be kind of incestuous. I mean, that's a good word, because it's like, look, you know, we're not trying to break into your group, but we want to make sure you're following the rules.
Yeah. Yeah. And protecting. I mean, because you may not realize it. You know, you started off by saying a lot of these were the best nurse that, you know, people didn't realize it. And so you just then enable this person to hurt themselves more because you refuse to do your due diligence, which you should be doing anyway, you know, per your license, right? So take care of if you really care about your people, then, you know, make sure you discard of your waste timely and you don't leave things laying out and you take responsibility for it. So there's more than one reason to make sure you're keeping an eye on your things.
Yeah, absolutely.
So, yeah. So advice for a CNO, I heard you say your checklist and some of those things that you put on there. Is there anything else that you would tell somebody taking on this role or an interim position, even as a nurse director? But
I would say trust, but verify.
Yeah.
That's another thing is, you know, people can tell you a lot of things, but data doesn't lie.
Yeah.
I mean, and I'm a big data person, you know, like I said, when I do an assessment, you know, I'll talk to people. But then I'll also ask for all the different data sources, like what kind of unexpected occurrences do you have? You know, what is your onboarding program like when you get new people, whether they're experienced or not? You know, all the different things that basically are risk related and patient safety related that become problematic, you know, especially if you're in an executive role. And so kind of looking at just the basic, you know, boots on the ground, how do things get done? And the other thing I always love to do is work shadow. Yeah. Because you can learn so much by just being back in the trenches, you know, whether it's, you know, a few hours, if it's an entire day, you know, you move yourself around the hospital. I mean, it helps you also get to know people and get to know, you know, their world. And I think, you know, it helps build trust. It's a great thing. You know, it's better. I even think it's better than rounding. I mean, because you can round yourself to death. Right. But if you don't but if you can't connect with people, you know, if you're working side by side with them for the day, you know, and you put on scrubs and you do whatever they're doing and you help them do whatever they're doing. I mean, it's always very, I think, impressive also for nursing staff to see that even though most of us are wearing a suit, you know, that every bit of nursing knowledge has not been purged out of our head.
Yeah. You would hope that you would hope they don't walk away saying, oh, she doesn't know what she's doing.
Yeah, exactly. That we really do know some things, you know, still, you know, and that we, just because we have a different role doesn't mean we forgot everything that we were, you know, the clinical parts of our training. And many of these things, you know, they don't change. It's like textbook. You do this thing in this way, and that's the only way you should do it.
Yeah. Okay. You did a dissertation on leadership fatigue, and I believe you have written a book. So let's talk about that. Can you share some main takeaways from that?
Yeah, sure. So I think when I started back to work on my doctorate, probably about 5 or 6 years after I'd been out consulting. So I'd been doing some interim and some consulting. And I thought, gosh, all of the places I go, all of the leaders, you know, look like, this is sort of a Suziism, looks like people yanked them through a keyhole backwards, you know, where they're just so like, it's almost like standing in the middle of a tornado where you can't figure out how to get out. And so I thought, I'm just going to make up these words and I'm going to call this leadership fatigue. And so we, you know, went to class like our first week, because it was a program where you had to present yourself for a couple of weeks. Then we went away for a year and we did our classes online. And then back the next year and saw the same people kind of thing. So we got to know some of our classmates as well. And so I think the first week they asked us if we had any ideas about our project, which was really going to be 2 years later. And I wrote those 2 words on one of those big, you know, yellow sticky notes. And all the professors that came in said, hey, what is this and who wrote it? And I thought, well, okay, this is good, because clearly it's like sort of a novel concept. And so I wanted to find out, you know, specifically in nurse leaders, because I needed to have a sample size that was large enough to be statistically significant, but small enough that actually would show whether this concept even made any kind of sense. So I did 2 focus groups. So some quantitative research based on, my definition of leadership fatigue, and then moved into, let's do a quantitative survey. So that was the 3rd step of the process, where I really wanted to find out if I sent this across the country. And so I actually leveraged my membership in the local and then the national professional association for nurse leaders, and asked them if they would help me, as a student, gather data. And so I really was very fortunate that all but 5 states really helped me. And so I had a sample size, which was pretty large, of about 525 people. The other thing I did is I cut it out by role. And so what I found was, because I wanted to know if there were nurse educators in the group, nurse managers, nurse directors, and then chiefs. And then I carved out just the chief nurses and used that to, basically get out of school. But I wanted the rest of the data sets because I wanted to see if there was any difference. And what I learned was that, you have to develop a thick skin. The more that you move up in an organization in a leadership role, the harder it gets. The harder it gets because you have, to figure out what are the priorities. You have multiple customers. You have metrics that you have to, kind of live and die by. That sometimes your compensation is based on success or a portion of it. And so there were different things at different levels that people just became, like, for example, with hardiness, people became much more hardy and much more tolerant to stress the more you moved up. Because honestly, if you couldn't or you didn't, you couldn't stand the job. I mean, these jobs will chew you up and spit you out. I mean, and I've always told people, it's a 24/7 job, but human performance doesn't allow you to, run 24/7. We're not machines. And your health and your mental health, your physical health and your mental health will suffer, if you don't have your own boundaries. And so I'm going to ask specific questions about those kind of things, like what kind of things do you do, related to stress, fatigue, and then typically, hopefully you don't get to burnout. And so I talked about, each of those, and like when you're feeling stressed, what kinds of things do you like to do? If you're tired, do you rest? And what kind of rest? Is it something like, for some people, they might want to go get a massage, and for someone else, they might want to go on a hike.
Or take a nap.
Yeah. And so, take a nap. I mean, so it's those different kinds of rest that are, we're doing for people. And then just specifically, I also talked about burnout in this dissertation. Well, interestingly enough, when I was in, I think it was about the 2nd year, so it was a 3-year program, I was contacted by a nursing publisher who asked about nurse burnout. And they said, we've been looking for someone to write a book. Would you be interested in that? And I said, well, yes, I'd be interested, but it depends on the timing. I said, because for my first priority is get out of school. Yeah. I said, and then I'd be happy to entertain the idea. And so, so I finished school in December of 13, and then the book was published in January of 16. And so I spent most of 15, working on the book, my spare time besides working. And it was great because I had a lot of information, from my own research, because my dissertation was about, 350 pages, and I had 62 tables of data. So I had a lot of really good information that was new and relevant. I also had a very hard time finding very much information that was leadership research focused in healthcare. I mean, so I had to go look in the psychology literature, the business literature, nursing literature. I looked at the medical literature, but it was very hard to find research related to leaders in healthcare. So when that book got published, then I went out and started talking about, my own dissertation and my results from my research, and then the book. And it was interesting because the audiences were all like, well, this is great. This is well and good, but what do we do about it? And so I thought, oh, hey, there's some more opportunity for, helping people figure out, okay, we're here and we want to go there. What do we do to get from here to there? Or what do we do to get better? If it's a personal goal. So I'm trying to think. Then I wrote another book for Sigma, actually, that was Sigma Theta Tau International, about business, because they asked the following year if I'd write a book about business. And so I did that. So it was business basics for nurses. And then we fast forward a little bit, and then we have COVID. And so during COVID, I was actually in an interim role during COVID in a very large hospital. I'd been there one day before it became a thing. And so that was a very interesting, many, many interesting months. Yeah. And so when I was finished, I said, look, we really need to revise the first edition of Nurse Burnout. Because by this time now we're into like 21. And it was from, 15, 16. And so I said, but I want to retitle it. And I said, I want to widen the audience. I said, I really want it to be applicable to everyone in healthcare. And I want it to be called Beyond Burnout. I said, because I was waving the white flag 6 years ago that we're headed towards the edge of a cliff. And then, of course, COVID was the cliff, basically, I think. There was a lot of things that went on in healthcare before that were, kind of under wraps. I mean, we all knew that it happened, but the public didn't know.
Yeah.
And then, when COVID came, it basically blew the lid off of all the things that we all knew. Yeah. But really that other people didn't know. And so we published it in, April of last year, 23. And then I also convinced them that we needed to do a workbook. So we actually, in the book, there are at the end of every section or through the sections, like each chapter, there are practice pearls. And so I wanted to put in there, okay, here's a bunch of verbiage, about this, that, and whatever else, and a bunch of current research. But then here are some takeaways. And so the takeaways were the practice pearls. And then what we did in the workbook was we took the practice pearls from every chapter and said, how do you implement these? How do you de-stress? What are some ideas for, managing stress? And so then actually put action items against each of the practice pearls so that you could basically read the book and then you could use the workbook to implement changes for either yourself, your organization, a book club, a leadership group, training in an organization, in school. There's actually a chapter written for students. And so we really try to cover, a wide audience of how could the information be used? And so, the results have been favorable. I've been out, speaking about the book and talking to people, and you can see here behind me. So Beyond Burnout right here. Like I said, published by Sigma Theta Tau International, which is a, Nursing Honor Society type publisher. Widely available though, Amazon, Barnes and Noble, pretty much anywhere people buy books, and you can buy an electronic format, a book format.
Sounds very practical.
Yeah. And that's really what we wanted was, it's fine that the five of us have all different kinds of knowledge from our over 100 years of experience, but how do you convey that information to other people and how can they apply it? And so I think, that's the most important thing is to, look at things like, do you have an internal locus of control or is it an external locus of control? And so many nurses, not the leaders, I would say, people that are nurse leaders, but the nurses in a lot of cases, think more about things being done to them versus them controlling how things are done. And so it's a different, it's a different mindset about locus of control. And so we talk about some of those kinds of things in the book. We talk about, just mindset. Do you have a growth mindset or is your mindset fixed? Are you open to change? Are you open to experimentation, in a controlled sort of way, and doing things different? And, so talking about that and how that actually impacts, stress, fatigue, and burnout. And certainly if you have more of a fixed mindset, it's more of a negative connotation, so to speak, and would be negative for the outcome. And then the other thing is one of my travels, I actually ran across a book called The Upside of Stress by Dr. Kelly McGonigal. And she's like an adjunct type professor at Stanford. And what she basically said is that, there is an upside to a certain amount of stress. So not all stress is bad. And I think that's the other thing is that you can't look at stress as your enemy. I mean, you can look at it as an acceptable amount of stress can be useful for peak performance, like peak human performance. Like if you look at athletes, for example, when they're getting fired up for whatever their sport is, that you need some, adrenaline and some stress to have peak human performance. But what happens is it was where it gets overdone and your body goes into that, cycle of having, too much cortisol, too much adrenaline. And then people start having, health problems and mental health problems. And so I think, understanding that, that really your health is wealth and that you really have to look after yourself and, and kind of know yourself as far as, what things are good for you and what things aren't necessarily. And things I'm talking about are like, nutrition. Sleep, there's lots of new research about sleep and about, sleep and weight loss, sleep and stress, sleep and, health, so to speak. Exercise is key. I mean, that's another thing. Like that's one of the things I use, for stress reduction is I've always been an exerciser and I notice when I don't get it, that my mind and my body need it. Yeah. So looking at, all those in various areas, of having, balanced relationships, and, having some fun built into your life. And so all the things that, make your life more balanced, not kind of like all work and no play.
Yeah. Yeah. It sounds very practical. I have two questions for you. I'm going to ask them both at the same time, just so that I don't forget them. And between the two of us, we can remember. The first one is, have you gotten any feedback from people that have read the book and like given you feedback on how it's made a difference or things that they have done and it's really changed things? And then two, do you feel that substance use disorders and burnout, fatigue are related to each other? Like, did you come across any of that with your research, or do you just have any thoughts on it based on all your research?
Let me answer the second question first. Do I think that, those are connected? I do. I mean, because I think honestly, when people are too stressed or overstressed, they look for ways to mitigate the stress. And like I said, with my own research, sometimes it's people use positive, but
other times it's a glass of wine.
Yeah, and exactly. And other people sometimes use substances, and it can be anything. It could be legal substances, it could be cigarettes, it could be food, it can be, and then it can be things that are not legal as well, or things that are, sort of illicit. And so there's all different kinds of, addiction, so to speak, that could be unhealthy. And then, even some things like people that exercise too much, that's probably an unhealthy addiction. So I mean, so I think that's the other thing, is finding sort of a balance. But do I think they're connected? I mean, I do. I think the amount of stress that people are under today, and if you look at the just general population percentages of people that feel burned out, I think it's like 6 in 10, 7 in 10. Many reasons for doctor's office visits, you can tie back to stress. So there's lots of interesting information coming out, in the medical literature as well, that, different kinds of stress are potentiating health problems for people, and if you're, lack of time, under stress, people make different choices, like even as far as food, we're starting to really understand, that nutrition is medicine, like food is medicine, and certain kinds of food and certain types of food, interact differently with your brain, which obviously affects people's ability to think and cope, and their coping mechanisms. So I think, a lot of that is pretty interesting, but I think, that there probably are some elements where they're definitely tied together. Now, whether anybody's actually done any research, I'm not sure. Now, as far as the book, I don't get too many direct messages, but I think, anecdotally, the people that I've sent some, copies to various people, and people have read it, and the people that, I had 4 different people that worked on both the books with me as well. That have used them. 2 actually have used them in academic settings. And so I think, I've gotten really good feedback from those people. And, kind of in general, just looking at sales, I mean, that's another thing that always gives me an idea of, okay, is this working? Is it doing what it's supposed to do in the industry? So I don't get too much, sometimes people will mail me, especially students, and want to know if they can use certain things, if they're doing their own smaller research project, or they want to use it for a paper or that kind of thing. And, I'm always really open to that.
Yeah. That's a good indication. All those things. Yeah. That it's making a difference for people. And really, I mean, I'm sure it's made a difference for many, but really if it just makes a difference for, a handful, it's probably worth it, because it's an important area. So, okay. Well, that's great. Well, I want to thank you for your time. This has been fascinating, and especially all the research and stuff that you've done. And you certainly have a lot of experience to wrap up the whole package, and kind of see what's going on out there. So thank you very much for sharing. Is there any final words of advice or anything that you'd want to give anybody that's listening out there, either a leader or just someone in healthcare? You've given plenty already, but
gosh, I was going to say, any final words of advice is you have to take care of yourself. You have to remember to take care of yourself, because sometimes, nobody else will remind you. And, I said, especially in a leadership role, the jobs are 24/7, and you have to, have your own kinds of boundaries. And, if you don't, they'll pretty much chew up and spit you out.
Yeah. And recognizing too, I mean, we feel that sometimes we don't have the time, but we will be a better performer if we take care of ourselves. So we're really not doing anybody a favor by, gotta work. The other thing that's kind of interesting that might be a good closing exercise is to work sample yourself.
And so, basically you can use a piece of paper, you can do it on your phone, you can use a spreadsheet, but really to look at all the hours in the day and to just log, what do you do and what do you spend your time doing? I mean, very insightful. You can track it over a period of weeks because, there are certain things in your role, specifically your job, that you can't say no to. But there are many other things that I think, doing something like that will identify areas where you may be able to make an adjustment.
Yeah.
And delegate things.
That makes sense. Yeah. Sometimes at the end of the day, I'm like, I was so busy. What did I do? Like, I have nothing to show for today.
I understand that. I completely understand that.
Maybe not what you're talking about, but sometimes that happens to me.
Yeah. My husband tells me I get sidetracked.
Yeah. It's like, well, I'm sure there's something I did, but I don't know. Anyway, but a lot of little things that didn't mount up to anything, and certainly nothing on my list of to-dos. Yeah. All right. Well, thank you very much, Suzi. I've enjoyed my time with you. Thank you.
Yeah. Thank you, Terri. And I hope I helped some people in your audience.
I'm sure you did. It was great information. Thank you.